echo my colleague Michelle Zong's comments. We agree. She did a very good job of summarizing. I just want to say that, we did talk about the hospital issue extensively, but this is a key issue for physicians, especially those that are in private practice, because this type of a plan shows a mentality to drive private practice physicians into an employed service, and that's not really what you want. You want to have a mix of physicians. As I traveled throughout New Jersey meeting with various physician groups, I'm very distressed to see the atmosphere amongst our physicians. There's clearly an element of fear that they do not know what is going to happen. And I think, a lot of times legislators think that doctors have a lot of control over what is going on. They actually don't. This is a very prime example of the power that this insurer has, especially since they are the largest. And there is no doubt that whether OMNIA goes forward with modifications or as is, it will change the healthcare landscape. And we are in a precarious environment where you saw the recent New Jersey Business and Industry Survey that 95% of all physicians are concerned. Reimbursement prior to OMNIA is already on the decline, because when it stays in a state like New Jersey, when it stays level, and because we have the highest taxation rates and everything else, it's declining, and it's a concern. If you were prior to, let's just say you were participating in the New Jersey State Health Benefits Plan under Horizon, and you have state employees like in Mercer County. Physicians in Mercer County have a lot of state employees coming to them. Those physicians, Chairman, you came back at a great time, because you have your little chart with the co-payments. When physicians, so prior to OMNIA, those patients going to our physicians in Mercer County had a low, maybe a $5 or a $10 copayment. Now you're going to a $50 or a $60. So that's a big deal when you're on a certain income. They may love their doctor, but they're going to have to say, sorry, Dr. Conaway, I can't go to you because this is going to strain my income even further. There's a lot of considerations, and just so that so Horizon, when they spoke to the doctors that were tier 2 that had concerns, they said, Doc, don't worry. Your income will be this. We're not going to reduce your reimbursement. But guess what? It'll be zero, because the patients are not going to be able to come to you. So, these are just the common sense concerns that, quite frankly, I'm going to turn it over to our president, Dr. Pedowitz, because he is a practicing tier 1 physician in a tier 2 hospital. But the fact is that those of you that are here, are elected officials, you are the only ones that can help. This is the one situation that your influence is going to help so much. The physicians of New Jersey are looking to Trenton for leadership, both from our medical organizations and from you. And we are going to look forward to working with you in the days and weeks ahead to try to resolve this. Thank you very much.
Thank you, Mr. Clark. Dr. Pedowitz.
Chairman Conaway, Chairman Gusciora, members of the committees, thank you for the opportunity to speak today. I did also testify in the Senate hearing, and I appreciate the opportunity to testify today. And I look forward to a little bit more of a discussion and conversation regarding this serious issue. As stated before, I am the president of the New Jersey Association of Osteopathic Physicians and Surgeons. I'm also medical director for family practice of Center State. Center State is a parent organization to my group where we practice family medicine and primary care, over 6 offices in several counties. I personally practice in Hightstown, Mercer County, and Freehold Borough. So I take care of a large portion of state employees as well as Medicaid and underserved population comprises the majority of my patients. We are a level 3 patient-centered medical home, which means that we've been recognized nationally and by Horizon, as well as other insurers, as being at the top tier for providing quality health care at lower cost. When I got a letter from Horizon that said, congratulations, you're a tier 1 physician, I said, I don't know what this means, but it sounds good.
Better tier 2.
Yeah, better tier 2. So I said, yeah, tier 1 is better than stepping in number 2, I guess. But I said, look, this is great. It was actually great news for me, but I didn't know what it meant. So we asked around, and I was told, well, you're patient-centered medical home, so you're tier 1. Congratulations. So as president, I traveled around the state, asked a lot of my colleagues. Some were in medical homes, some were not. There was no rhyme or reason. Patients were in medical homes, or doctors were in medical homes dropped. and some doctors were not inpatient at medical homes, and they were tier 1. One of my colleagues who's in the room today, Jesse Stowicki, who practices at St. Francis, and he's also in Mercer County. He's a tier 2 physician. He asked his contact at Horizon for some criteria, and after several emails and communications back and forth, he was given this email that stated, and he's given me permission to read this. Just the highlights of this, that specialties were evaluated based on one or more of the following criteria. 1, cost efficiency metrics. Risk-adjusted cost efficiency at a group practice level using episode treatment group data. To qualify for the ETG analysis, practices were required to have a minimum of 50 episodes of care between July 2013 and July 2014, processed no later than September 2014. Most of us have no idea what episode treatment group data means. Number 2, admission privileges and referral patterns to OMNIA Tier 1 hospitals where applicable. 3, geographic access and coverage standards. Your office must meet all the criteria above to be OMNIA Tier 1. And then it goes on to state that even if you are a Tier 2 physician practicing in a Tier 1 hospital, you'll be reimbursed only at your Tier 2 rates. I read this email and said, that's interesting because I don't meet all 3 of those criteria, but I'm a Tier 1 physician, so why is my colleague, Dr. Stowicki, not a Tier 1 physician? Further problem is I practice in a hospital system. I'm an employed physician at Central State Medical Center, Tier 2 physician. I see patients in the hospital. One of my office locations is adjacent to the hospital system. I have patients that I take care of in the hospital. I'm seeing them in my practice. I'm a Tier 1 physician, and I say I have to admit you to the hospital, unfortunately, and they know what's going on. If they have an OMNIA plan, these discussions have now been happening. To give a few patient examples and see what it's like in the trenches, because we've heard, people have said, hey, there's jumping around and people are going to change practices in hospitals, and there's a lot of theory on that. I'm here to tell you it's fact. I had a patient 2 weeks ago, well, several weeks ago, who I saw needed physical therapy. He has federal Blue Cross Blue Shield, not an OMNIA product. I sent him to my hospital to see a specific therapist who I knew could help him for this sports-related injury. I saw him in my office a couple days ago, and he said he was not better. And I said, well, I don't understand. The therapist I sent you to is really good. I've never seen anyone come back not feeling better. He said, well, I didn't go to your hospital. I went to a different place. I said, why? He goes, because you're a Tier 2 hospital, and that's going to affect me, and I didn't want to pay for it. And I said, well, hold on a second. First of all, you don't even have OMNIA. And I said, second of all, I don't understand. You've been going to this hospital for everything your entire life. Why did you choose now? I got a letter from Verizon, and the way I read it was, if I have Verizon and I use your hospital, I'm going to pay more. So I figured I might as well start now using different systems and different services. And I just have to highlight here, because I tell you, this kind of thing is absolutely outrageous. And we've seen this in other contexts. I've networked on other things, that these letters go out. And I don't know if that is, that's actual or not. I guess it didn't affect you directly. But these kinds of missives that cause confusion to patients, it seems to me that somebody in the government ought to have responsibility about that. And here's a patient who made a decision based on something that probably didn't affect him. And now his care has been compromised by that. There are issues now with communication being provided. He had an expectation about what kind of care he was supposed to receive, and that comes up. So these are the kinds of things that are happening. And I tell you, we need to take cognizance of that in this legislature, in this government, because this, what you're describing, is not at all unusual. It happens with great regularity to the detriment of patients, and it really needs to stop. Go ahead. So, my fear is not only patients like this being swayed by marketing techniques, and whether it's fact or fiction or misunderstanding, it really happens. I've had several other patients that are now coming to me as new patients saying, I looked you up on the network, you're Tier 1, I'm switching from my provider who is a Tier 2 or not in the network at all. And likewise, I've had other patients that say, I'm switching out of your practice because your hospital, where I want to get care, is not Tier 1. And I'm sorry, doc, I love you, but I got to go where I can save money. And I've had other patients that say, I'm going to use you as my doctor because you're Tier 1 and I like you, but I'm going to go to a different hospital system anytime I need services. And I put my hands up and said, I don't know what to tell you. I'm going to take care of you the best I can. I'm going to fight the fight. I told them I'm going to Trent this week. and see what I could do. So, my fear is, when you have insurance companies like Horizon, maybe with the assistance of Adobe or the lack of oversight that has been used quite a bit today, deciding who is in, who is out, who is quality, who is not. This is a very, very dangerous precedent. And I think if we go down this slope, we will see the demise of quality health care for all of our citizens in the state. And I really can't stomach that. And I hope that everybody in this room can work together. I think quality, saving money, I agree with Horizon's efforts in this case. But I think the plan needs to be halted. We need to look at this and make this affordable quality care for everybody involved. And any physician, any hospital should have the same right, the same ability to meet those standards. And those standards need to be published and not erroneous, as this email might have indicated. Thank you.
Well, that does seem to be a theme here of late from folks who've offered information to this committee that are concerned about standards, about their application, that they should be fair, and that ideally everybody who can meet them ought to be in. It is a, now, insurance companies will say, well, if everybody's in, then I can't go and offer someone volume and get a discount from them to steer patients to them. And, but wait a minute, I have good outcomes. I have, if I'm a tier 1 provider and they go to my hospital, I have access to the labs in the hospital, I can easily access their discharge summaries. The continuity of care situation is very much improved. How is that not best for patients? And by the way, with all that's going on, relationships that I've had with patients, years in the making, decades in some cases, now they're severed and they're broken. How's that good for patients? This is what this hearing process means, and everybody in this committee and this legislature needs to be aware of this, where the physicians are concerned patients. You're talking about severing relationships that patients have with their physician. And all of this talk about getting increasing care, improving outcomes, a lot of it's centered where? In the physician's office with long-term preventative care being handled by someone who knows you, who follows you through the arc of your life and is providing the kind of care you need to extend your life and enhance your life as it goes forward, being broken by this tiering system that is going to be applied to physicians. We're not going to achieve what the hope and the promise of these cost savings if patients are going to be ripped from the physicians, driven as they will be, as the expectation is, by these out-of-pocket cost considerations that are part of this plan. What do you think of that? Ms.
Sorry, Chairman, if I could just add one more thing. Just to kind of emphasize the issue of the squeeze that the physicians and the hospitals are facing. So, I've said already that if you're in Tier 2, you sort of, the point of having your contract is negated. The problem is, instead of legislation that improves that landscape and levels the playing field and acknowledges that the contracts are unilateral contracts of adhesion, what we're seeing instead is legislation move forward that would punish doctors for going out of network. And those two things combined are going to be detrimental to patient care.
Well, there are a lot of people in and around this policy space who think that all physicians want to be employed. Now, how do you achieve that goal and everyone on the network? I mean, there are actually people who propose bills and processes that would drive everybody into a network. And whether you think it's in your financial interest either or not. No, I'm not sure what that's called. I use the word slavery. I think if you are forced to give over your labor against your will, I sort of think that sounds like slavery to me. Now, you have this idea out there that the independent practicing physician is sort of a dinosaur and really needs to be sort of wrapped up in a hospital system or some other large organization. Now, how do you achieve that? Well, one way to achieve it would be to enforce this tiering process, begin to break apart the relationship between doctors and their patients. Because, as you have already mentioned, Justice Sawicki, who's here, Dr. Sawicki, we had this conversation the other day, long-term patient, concerned and looking to the future as people do. Can I stay with you? I'm healthy now, but, I'm up in years, I could need to use hospital services. The hospital, but you know, if you follow me in the hospital as I expect you to do, you're my doctor, I'm going to have to pay a lot more for your care because you're a tier 2 doctor handling that episode of care. I don't know that I can stay with you. Or if I'm with a tier 1 doctor and I go to a tier 2 hospital, my out-of-pocket costs for in-hospital care. So I have to change, the relationships then change. And so, now, if I'm a tier 2 doctor, what might I do? When the hospital comes calling and says, I want to buy your practice. Now, one, what is the value of my practice now? The landscape has changed such that my practice has been devalued. I'm a tier 2 doctor. I've negotiated with the hospital over if I decide I want to go there. What's my negotiating position now that I'm a tier 2 doctor vis-a-vis the insurer with the largest footprint in the state? What happens to the value of my practice in that situation? What happens, and as I said, so this whole process is one that needs very close scrutiny by this legislature, what this means. Do we as a policy think that all physicians ought to be employed? Because that's where it seems that we're heading, and that's what this program seems to suggest to me. And I tell you, I'm an internist. I've had long-term relationships with patients. And it is one of the things that we in primary care cherish when we do that. And not even only internists, but people who are surgical practice in life have patients that they've known for years and years and years. And it's part of the enriching part of being in practice. This process, you talk about quality of life in medicine, very detrimental. And then you get down to the nitty-gritty facts of the dollars and cents. And it is again, a detriment to physicians. And this hearing, and worse, it's in a black box, you don't even know. I looked up this episode treatment group, and I'm going to read what it says here, and see if you can figure it out. I haven't quite got it yet. I'd like to read it a few more times, I think. Is an episode grouper for medical and pharmacy claims. It provides a condition classification methodology that combines related services into medically relevant and distinct units, describing the complete and severity adjusted episodes of care and associated costs. Now, if anybody out there that can explain that, that person I think is reasonable intelligence. What that means and how I stack up against that, I'm all ears. I'm ready to be taken to school. But I tell you, we need to look at this process. We need to think about patients and the doctor-patient relationship and decide, we're going to have to make some policy decisions whether or not there's a role for the independent practice physician in this landscape. Because this setup is designed to mitigate against that and I think it's bad for patients and it's certainly bad for physicians as well. Questions? Ms. Sumter.
Thank you, Mr. Chairman. I felt your passion over here. with
I won't tell a story necessarily, but hopefully something memorable anyway.
Absolutely. But to my physicians here, if you don't mind, because I've spoken to a number of physicians as well, and their concern is that their patient population who they built these relationships with over the years have received these notices from their insurance company without any input from them. And if their patients, or once they got back in network, there was no notification sent back to the patient that, okay, now they're affiliated with a Tier 1 hospital. So they have to then chase those patients again. So are you communicating any type of correspondence with your patients about these changes in the system, or is it just solely the insurance companies communicating with the patient populations?
Yes, I think we can answer at least from our perspective, and also just to address some comments by Chairman Conaway, if I can handle. First of all, it is, I believe the same way, but it is my goal as president of NJAOPS, and I'm sure the goal of MSNJ is to protect our independent physicians. And whereas many physicians, including myself, are employed, it certainly would be my goal and our goal to protect the rights of physicians to be individual business owners like any other business, like any other ability to self-manage and take care of their patients and not disrupt the physician-patient relationship. With regards to communicating with our patients, as you asked, I can speak for our hospital system. We proactively, our CEOs proactively send out letters to our patients, everyone, about proposed changes at the time, what it meant, what our hospital was doing about it, highlighting the benefits that our hospital provides, and we've certainly been having that communication with our patients on a day-to-day basis when they come into the office. We do have community outreach coordinators, nurse navigators that are having conversations with patients, counseling them about which insurance plans to choose, why they would make certain choices, benefits. So we're trying, but can you reach everybody on an individual level? It's difficult. Are we losing people to this particular issue? Absolutely.